Congenital orbital cyst. Disclosures. Introduction. Congenital orbital cyst is a rare ocular and orbital malformation. It is a cyst or a cavity in the orbit lined by neuroglial tissue. There may be a microphthalmic eye. The eye may have normal vision potential. The pathogenicity and epidemiology caused by failure of fetal tissue fissure to close and the proliferation of neuroepithelium through the opening. Can be associated with microphthalmos, usually seen at 4 weeks of embryonic life. Microphthalmia with orbital cyst, rare with no prevalence rate. The prevalence of microphthalmos is 1.4 to 3.5 per 10,000 births. Can be unilateral or bilateral and can be associated with intracranial anomalies. Clinical presentation. Usual presentation is inability to open the eye at birth due to an orbital mass. The cyst is of variable size, transilluminant and grayish-blue in color. Microphthalmic eyeball is shifted upwards. Enlargement of the cyst due to fluid produced by the glial tissue. Duke-Elder's classification for orbital cyst consisted of relatively normal eye with clinically inapparent cyst, grossly deformed eye with an obvious cyst, type 3 large cyst which has pushed the globe backward, rendering it clinically invisible. Ultrasonography and to be done in these cases. Rapid, non-invasive determines the status of the eye. B scan shows large orbital echo lucent cyst indenting the globe. A scan shows low internal reflectivity filled which is with fluid in the cyst. CT scan shows a mass is hypodense. The globe may be small. Single or multiple cysts may be seen around the rudimentary globe. Large cysts produce remodeling of the orbit. MRI scan, which is safe in children, shows volumetric analysis. It detects communication between globe and cyst. Differential diagnosis in the form of congenital cystic eye, meningocele, arachnoid cyst, primary optic nerve sheath cyst, teratomas of the orbit. In histopathology, one sees an irregular shaped cyst wall covered with collagenous connective tissue. Inner layer composed of neuroectodermal tissue with varying degrees of differentiated retinal elements. Calcified bodies with cells containing melanin granules are seen inside the cyst. Histopathologically, cyst in microphthalmic eye is similar to the congenital cystic eye. In congenital cystic globes, the cyst is located centrally or slightly upwards in the orbit. Histologically, it lacks normal ocular structures and shows the presence of cyst lined with neuroglial tissue. In microphthalmos with cyst, the lower eyelid bulges as the cyst is attached to the inferior portion of the globe. Management is usually basic approach is based on age of presentation, visual potential of the microphthalmic eye, expansion of the orbit. Cyst is just kept under observation till the age of 6 as the cyst promotes orbital growth. Intervention: if the cyst enlarges and produces asymmetric growth of the orbit wall, prosthesis cannot be fitted due to the cyst. Cyst is prolapsing from the palpebral fissure. Volume of the cyst orbit has increased compared to the other side. If the cyst is small, observation is recommended till the age of 7. Large cyst affecting cosmesis, aspiration and sclerosant injection. Excision of the cyst should be done if recurrence occurs. In case of severe microphthalmia, both the cyst and globe should be excised with replacement of volume. Aspiration of cyst and injection of sclerosant. The various sclerosants used are N-butyl cyanoacrylate called Nectacryl. The glue solidifies inside the cyst and can be removed easily. Sodium tetradecyl sulfate, it is used as a sclerosing agent. When injected, the cyst gets fibrosed and can be removed easily. Fibrin glue, by injecting into the cyst after aspiration of the cyst wall collapses and the walls get adherent. Congenital microphthalmos in a bilateral case. The cyst is seen as a mass in the lower eyelid on the right side. Eyeball has been pushed up. The CT scan showed multiple cysts of varying sizes seen bilaterally. The cyst seen on the right inferior orbit measures 2.42 into 1.6 centimeters. Cyst in the left posterior periocular region measures 1.3 and to 1 centimeter. Both the optic nerves are smaller in caliber. The volume is 13.2 on the right side and 10.2 on the left side. The microphthalmos eye is shifted upwards, as you can see even in the CT scan. Congenital bilateral orbital cyst with bilateral microphthalmos. Nectacryl injection was given on the right side and cyst was excised. Eye shell was given on both the sides. Bilateral microphthalmos with orbital cyst. Right side cyst removed as orbit was getting enlarged. Eye shell on both sides. Left congenital microphthalmos with contracted socket. Expansion is done with expanders. Conformer used once expansion was sufficient. Orbital cyst seen as a bluish mass. Congenital orbital cyst on the right side. Enlargement of the orbit seen in CT scan. So a sclerosant injection of sodium tetradecyl was given. It shrunk. There was no recurrence 3 months follow-up. Microphthalmos with an orbital cyst. The cyst excised due to expansion of the orbit. One can see the cyst here attached to the shrunken eye. Sclerosant injection into the cyst on the left side. The cyst excised to fit a shell. Patient developed an entropy which was corrected. And a cyst very anterior seen in the right eye. It was excised for cosmesis. The eye is normal. Congenital microphthalmos with contracted socket. Gradual expansion with expanders. Conformer is placed. To expand the bony orbit, acrylic implant was used. Implant got extruded due to enlargement of the cyst posterior to the implant. Note the growth of the eyelid. Orbital cyst seen in the CT scan. Cyst was removed and acrylic implant placed. Preoperative picture was not available in this case. Implant had migrated superiorly, indenting the roof of the orbit, so it was removed surgically. Attempt was made to place an eye shell. Contouring the bony orbit was done later. Correction of the dystopia patient had by elevation of the floor by implants. Inferior fornix formation, supratarsal fold creation, and good cosmesis were cleared. The further improvement was tried because absence of an eye is very traumatic. Multiple procedures are needed to give an eye with fair cosmesis. This case is an example for it. The child was seen when he was few months old and he is now a teenager. The patience and perseverance of the mother has to be appreciated. Orbital cyst, initially it was sclerosed and subsequently excised. After placing an eye shell, ptosis gets corrected also. Conclusion: orbital cysts, which are congenital, are quite rare. Treatment is planned according to the age of presentation. To get a good cosmesis, multiple reconstructive surgeries are needed.